We will begin our workshop today with a presentation from Florida Hospital and Advent Health. So, Sarah, you're on the list here. Are you turning it over? How are we
I
doing
will
this?
turn it over.
Okay.
All right.
Passwaters will make introductions for the team.
Okay.
Thank you. Appreciate that. Rob Passwaters is my name, and it's a pleasure to be here today. With me is Dr. Peter Schuck, and why don't I let you guys introduce yourselves?
Sure. My name is Dr. Peter Schuck. I am an internist by training. I joined Advent Health about a year ago and served dual role as their Senior Vice President for Population Health here in the Central Florida Division and the President of our Clinically Integrated Network, our physician network in the Central Florida region.
Terrific. Mark Martin. I have responsibility for network development for Advent Health corporately.
So thank you for your time. Appreciate your patience and flexibility.
Can you tell me what network development is?
Sure. Responsible for the development of the network that services patients, members within the health plan, as well as the types of arrangements that we've put together with the school
Okay, so
district.
it'd be clinics, hospitals,
Yes.
central care, or whatever?
Right.
Okay. I'm with you now. I didn't figure you were the IT guy, but
Sure, that's right. Far from it, yes.
So we've got a couple of folks with us. So David Midag is Director of Operations, so he has direct responsibility over the clinic. Sherry Carrick,
I'm Director of Business Development and Marketing and part of Mark's team.
and then Jill Piazza.
I'm Jill Piazza. I'm the Vice President for Care Integration with our Population Health Services Organization. I oversee our care management programs.
we don't have long titles.
So thanks again for your allowing us to come and present today. What we'd like to do is we'd like to just take a quick glance back and look at some of the objectives when we started the clinic, and then how we're performing, and then look forward at where we would like to recommend that the partnership go, look at some opportunities moving forward. So it is our pleasure to serve in the clinic, and this all started about 3 years ago. April of 2016, April 24th, we opened the clinic after working with the team to design the clinic and build the clinic. We started with really a primary care focus and staffed the clinic. We've been, one of our biggest tasks was to promote the clinic, start to let people know about the clinic and start to grow volumes. I mean, I think that was our first task to do. And so we worked with the district, did lots of marketing. We hired an individual that spent a lot of time out of the schools promoting the clinic. And so the big challenge when we started was that 41% of the population had no relationship with a primary care provider, hadn't seen a primary care provider. And so our first task was really to try to reduce that number and to do that through the clinic. And so in the last 3 years, we've actually reduced that 41% down to 13%. And so we have had a wonderful attribution to the clinic in terms of adoption. If we think about the number of folks that we've seen, we've served almost 8,000 unique individuals. Over the last 3 years, almost 70,000 visits. And then if we look at the experience in the clinic, we do an internal survey. So after every visit, we ask people about their visit, what their willingness to recommend is. And if we think about a rating of 1 to 5, 95% of the time, people say it's a 5. So they've really appreciated the opportunity and the experience in the clinic. We also care about our reputation. So social media, as you know, is increasingly important, and having a good reputation on social media is a big deal. And so we're at a 4.3 star rating when you look at Google. Now, we've had some challenges along the way. When we started, we really did focus on primary care. And what we found, albeit a little late, was that there was great demand for same-day service. And so meeting with the superintendent, talking that through, what we've done is we've flexed our staffing, staying within budget, but we've provided another resource to really see those same-day visits. Yeah.
Can I ask a question?
Sure.
So, define same-day visit for me.
Okay.
I mean, because I'll tell you where I'm coming from as a
Yep.
just a bovine specialist,
Mm-hmm.
Which is my title. I will. You weren't here earlier. My primary care physician. The only time I call him is if I need same day service. I mean, so define that for me in your terms.
Sure.
I don't go to the doctor for anything. I mean, I'm relatively young and relatively healthy, so I go to the doctor when I'm sick.
Peter, you want to take that question?
Sure. I think our goal is to have same-day access mean the same thing that it does to the consumer, right? That's where we're headed. We all know that traditional healthcare has not been in that vein. Same-day access has been 9 to 5 if it's convenient for us. We've made a lot of strides over the last number of years to provide venues of care where that's not the case and to transition our model into something that is much more consumer-centric. So same-day visits means that you would call that day, need to get in for an appointment, and we'd say, yes, come in, either from an appointment for a scheduled appointment time or walk-in availability within the hours of clinic operation.
Right. So really, I was thinking primary care.
Oh,
so,
I'm sorry.
So when we say primary care, often we talk about chronic care management.
Yeah.
So things like diabetes, high blood pressure, things like that, where you would come back on a regular basis to see the provider, and we're really managing a disease state. So like Dr. Shuck said, when we think about same day, we're really talking about the acute issue. Got the flu, I don't feel well, I want to walk in same day or call and come in the same day.
But to my point, that's what I call my primary care physician for as well.
Yeah, no, and I get what you're saying, and I think I totally get what you're saying, and I'm an internist by training, practiced primary care for 20 years before changing my white coat for a blazer, right? But the reality of it is, I absolutely agree with you. I don't go get my car inspected when I get the notice. I moved from Missouri, so we inspect.
When I call up a mechanic, I want same day service.
Yeah, right.
Right.
Because
it's
I'm
my
doing
primary care mechanic that I call.
Right, and I'm doing it on my time, right? And so we do get that, and I understand that disconnect right now sometimes.
Okay.
in the
I
healthcare
just
space.
was looking for the definition. I appreciate it, and I'm not trying to be.
No, not at all.
That's
Well,
where I was at.
but the truth is, there was a gap, and so I think there was a buzz in the district. In fact, I heard it from an old PE coach that I work out with that can't get into the clinic same day. And so what we've done now is we don't deny anyone. So we're not trying to schedule them a day later or 2 days later. If you want to come in same day because you want to see your mechanic that day to fix your car, we're going to see you. So today we're seeing 30 to 40 acute issues same day with nobody being turned away. Now, every once in a while, there's a little bit of a wait time under that,
Sure.
but we're seeing everyone that wants to come same day. Now, if I think about, so the last bullet on there is the other thing that we wanted to do was to provide occupational health services in the clinic. And so there's a cost to occupational health, work comp, DOT physicals, things like that. And so it was a desire to bring that into the clinic, save that cost, run that through our providers, and so we've done that. In the past, that's about $321,000 annually that used to be spent outside the clinic that we brought into the clinic. So that's been implemented. If I look at the next page, additionally, as part of our partnership, we didn't want to focus just on what was happening in the clinic. We also wanted to focus on what was happening outside of the clinic. And so met with the superintendent about a year ago, and we talked about telemedicine. How do we extend care beyond the four walls of the clinic? How do we reach the larger geography of Osceola County without having everyone come to the clinic? And so 12 months ago, we rolled out eCare. We've enrolled 650 members. We've seen through telemedicine 483 visits. And so we continue to promote that to the community, and we see more and more adoption happening. We've also provided as a system Advent Health through our hospitals almost $2 million of services to SDOC employees who have come to the hospital who have struggled to pay their portion of the bill, and we've actually covered that. So that's just another benefit that's been extended to the district employees.
Is that part of y'all's program, or is that because these people are part of the clinic in the school district, or how? My hunch is you provide some free services to them.
We do.
So would this mirror, I guess, general population, or not? I don't know.
I would say that it's a combination of the two. There's certainly preferential treatment given to the school district employees based on the relationships that we have.
Yeah. And I would say on the back end, after one of the school district employees goes to the hospital, there's a contact back to the clinic. We contact that employee, try to get them in for follow-up. So there's definitely connections between the hospital system and the clinic. In going out to the schools, our team also quickly saw that there were needs in the schools with students. And so over the past 3 years, our team has either directly donated the teams or they've raised about $200,000 in supplies that have been donated to the schools. So that's clothing, school supplies, food, different things like that. Really focusing on schools like Central Avenue Elementary and Highlands, Kissimmee Middle, some of those schools where the highest need is. And so that's been a real joy for us. That's one of those things that you get to do. And so being a close business partner with the schools and doing some of those things has been a real pleasure for us.
Great.
Pitch to Mark.
I want to walk you through a little bit of the history, as Rob said. So recognize that when we initially took over, one of the things that was important was that we got data from Cigna. So we really understood what the population looked like. It took us a lot longer than anticipated to get that data. We got that kind of in the late summer of 2017. And so we've really had that data now for about 1.5 years and have been able to utilize that as we develop care management programs and such that Dr. Shuck will talk a little bit more about.
Do you know why that took longer to get?
There were lots of issues that Cigna was concerned about confidentiality of data, and so there was a lot of time spent getting them comfortable with the fact that we were protecting that confidentiality and such. So it took literally probably twice as long as we would have expected.
Who owns the data?
The school district owns the data, but insurance companies often protect that data and should protect that data because it has
I
protected
understand the
health information.
confidentiality part of it, but in the end, this board owns the data, correct?
Correct.
Okay.
And so it's working at this point, certainly, but you'll see on a slightly declining population from 2016 to 18, we went from 9,712 members to 9,373. There was a significant portion of the population in 2016 that had no claims whatsoever. So a little over 1,360 individuals had no claims, no dollars spent, which meant they didn't see a physician. There were 5,900 that were not managed by the center. Now we've measured this in the most conservative terms. We've looked at the number of members who are attributed to the center, which we define as have 50% or more of their primary care services over a 2-year period of time. So we've measured that period of time from inception of the clinic through the end of fiscal year 2017. When we look at it for the previous past 2 years, these numbers are magnified a little bit, that there's more movement towards the center. So today, from 16, where we had 25% of the employees receiving 50% or more of their care in the center, that rose to 33% in fiscal year 2018 based on this attribution methodology. So there's an increase of the number of people being seen in the center, which, as Rob said, we saw 41% people with no primary care relationship to 13% at this point.
If I get the flu and I call the clinic and I go there tomorrow, but then I just go to my primary care doctor 2 more times, I'm in the 5,900, right? Is that what?
Correct.
Okay.
Correct. You're in the not managed. So when it's not managed by the clinic, but there are claims and there is attribution. So if we go to the next page, what we've tried to do.
I guess the important, but these numbers do not mean they have not been to the clinic.
Does not mean that they have not been to the clinic. Correct. Correct. When we go to the next page and look at the paid PMPY is per member per year, we see the light box at the top is those people who are going to physicians and seeking care elsewhere, but not as the primary care being sought within the clinic. And managed means where they are seeking care within the clinic. And then the the darker bottom box represents the combination of those two. So it excludes the people with no claims. We're trying to look at apples and apples to understand what's the experience inside and outside of the clinic. And what you see is that there was a significant increase in the cost from 2016 to 17, which represents in large part the opening of the clinic and the additional costs. So the costs that are in here are the costs that are paid for claims by the school district, as well as the cost associated with the clinic, which is about $3 million a year, really, from the inception. So that large increase in 2017, large piece of that was opening the clinic. And then if you go down to 2018, what you'll see is that the overall cost have decreased within the clinic. So overall, from 17 to 18, the cost went up 11.1% for both of these populations combined. But while it went up 19.4% for those people who weren't managed in the clinic, it actually went down 4.5% for people in the clinic. So I'm going to show you some statistics that the clinic is actually working as it relates to being able to manage the cost of those members who are there. And what we're going to be talking about for the remainder of today is the clinic is one part of a strategy, and another part of that strategy is how do we embrace those people who are outside of the clinic, who view choice as important to them, who are seeking care but are not seeking it through the clinic, because we're not being as effective as we are within the clinic. If we go to the next page.
I'm a little
Yes.
confused, if you can help me understand. On your chart, you have the not managed, I'm just looking at the top,
Yep.
6.3 million, the managed of 4 million,
Well, that's $6,300 per
or
year.
6,300 per, okay.
Right.
Remember per year.
So it's an average.
Okay,
Yeah.
so this total is the average.
The total is the average
Okay,
of those two
okay.
categories,
Yeah.
correct?
Yeah, it's not
Correct.
the total.
Correct.
Right.
That's it.
So if we go to the next page, really looking at inpatient admissions to try to understand.
I'm sorry to
Yes.
interrupt you. I wasn't here at the onset of this, so I need to understand, what is PMPY? What is the acronym?
Per
stand
member
for?
per year.
Okay.
So that's the cost per member per year. And you'll hear also used per member per month, PMPM.
Okay.
So as we look at admissions, we see that admissions per thousand in 2016 on a combined basis was 89.8 days per thousand. As a benchmark comparison, Florida Hospital's benchmark or for all of our employees, Advent Health is 70.3. So that 70 range is where the market really is on average. So in 2016, that number was higher than expected. It did drop in total in 17, going to 74.5 on average, and then 80.7 in 2018. But you'll notice that dark box, the managed box, has less admits per 1,000 than what's happening outside of the clinic. So again, another indicator that the people who are seeking health care and are not going to the clinic are more costly and are seeking or requiring hospitalization more frequently.
And you said this is not just I've been admitted, but days that I'm there.
No, it's an
Yeah,
admit
this is
rate.
admits per thousand.
It's an
correct.
admit rate per
Admit.
thousand population, yes, ma'am.
Okay.
Right. Right. If we turn to the next page, I think this helps kind of, in a snapshot, look at the paid dollars per member per month. So this is just the per member per year divided by 12, essentially, but it's breaking down based on the various areas. And on the left-hand side is that the population that's not managed in the clinic. On the right-hand side is that's managed in the clinic. And you see that from a variance perspective, which we talked about on an earlier slide, the dollars went up from $508 per member per month to $607 in that not managed population. So there was a 19.4% increase. Whereas on the managed population, it actually went down 4.5%. So that variation is pretty significant between not managed and managed. And if we look at, for instance, the top right-hand corner where it talks about inpatient, 2008 paid that $107.51 per member per month, compares a national benchmarks to a well-managed population. So again, I think that getting people into the clinic certainly is a key component, and embracing those in a different way than we've been able to at this point in time is absolutely necessary for those who aren't being seen in the clinic. The last slide that I'm going to go through before we'll turn over to Dr. Shuck is on page 8, which really just looks, because I know that there was discussion about, well, when Florida Hospital Advent Health came in, that there was a shift of business that went from other facilities to the Florida Hospital or Advent Health facilities. And while that certainly was the expectation, that's part of the network that we put in place, you'll see that from 17 to 18 in the far right, the highlighted columns, that the increases in spending between 17 and 18 in total was 15.9%, but it was a little bit less within the Advent Health facilities at 14.8% increase versus 16.7%. But probably more noticeably is only 43% of the total outpatient business is being done within Advent Health facilities, and almost 57% of it is being done outside of Advent Health facilities. And that's actually has declined. The amount from 2017 to 18 has declined a couple of percentage points. Same thing on the inpatient admissions or inpatient dollars spent. There was a 16.3% increase overall, a lower percent increase at the Advent Health facilities. And again, about 40% of the population is seen within Advent Health facilities versus non-Advent Health facilities. So again, there's been increases in costs, no question, and we understand the total cost of care concerns and share those with you. But it wasn't necessarily it wasn't a disproportionate move of everything into Advent Health facilities. It was across the board, and in fact, a higher rate of growth in the non-Advent Health facilities.
And did you compare this information to 2016 prior to the clinic?
I did not in the slide. No. That's a good question.
Okay. Peter? Yeah, I think, thanks, and I appreciate the opportunity to be here. And I'm going to walk through these next 4 or 5 slides kind of at a high level and kind of lay out a population health perspective and then what we think might be a roadmap to help really address the question, which is how can we as Advent Health partner with you to lower the total cost of care for your membership, not just those seen in the clinic, but those seen outside the clinic as well, which I think, as we heard when we met with Dr. Pace and Sarah earlier in the year, that was, or last year actually, that was a significant concern. So what you're looking at here on slide labeled number 9, high-cost members, is really around how much we have a common saying in population health that the top 5% of folks at the risk, top 5 highest percent of risk, accounts for about 80% of the spend within a plan. In this case, not quite 80%, but we can certainly see that the top 5 utilizers or spend across the top 5 high-risk patients that were managed by the clinics account for about $2.1 million in 2018. And if you extend that to the non-managed population, the top 10 members there added up to a total of $6.6 million for a total spend of around $8.5 to $9 million just on 15 members within your plan over that period of time. Now, at Advent Health, we have hundreds of thousands of patients across multiple value-based arrangements for which we're responsible for total cost of care. Some of those arrangements are full risk arrangements. Some of those arrangements are shared risk arrangements and direct-to-employer arrangements, and some are other value-based arrangements with different payers. In all of those cases, we have something that we call high claims thresholds, where we actually buy down through reinsurance the high claims threshold, such that any claim over $350,000, and we can choose the threshold, we pay a PMPM for it, and that's reinsured. In this case, that would have mitigated a significant amount of spend to have high cost claims threshold reinsurance on the current plan.
I think yours is currently at $850,000, which is a very high amount for the population that you have.
Yeah, there would have, and that's the highest amount that I've seen across any of our value-based arrangements here or at other locations. Yes, sir.
We've got a lot of this whole presentation is based on the managed by the clinic versus not managed by the clinic. But when I look at these high whatever you call the high-cost members here, a lot of this stuff, I mean, newborns aren't going to go to the clinic. I mean, your breast cancers are not going to go to the clinic. I mean, I would assume they're going to go to an oncologist in a year a lot more than they're going to go to get a physical. I mean, just kind of by the nature of what these things are. I don't know what those stuff are.
Yeah, I don't think from my perspective.
Once you get one of these things,
Yep.
you're going to, I'm assuming, you're going to go to the specialist that treats these things
Absolutely,
Yep.
yes.
a lot. So you're automatically a non-member or a non-managed. You by the nature of having one of these things, you become a non-managed person. Almost.
No. So again, if your primary care relationship is in the clinic, it doesn't matter what your hospitalizations or your specialist, you're still considered to be a managed member. If from a primary care
Earlier, when I
standpoint.
asked a question, if I went to the doctor twice and I went to the clinic once, so you told me I was a non-managed.
You said from a primary care.
Right, if you just went because you had the flu
Right.
or
Specialists with a
a
kid.
DOT physical.
Okay.
Yeah, if you go there for acute visit versus receiving your primary care there.
Right.
So question, on the high cost claims threshold reinsurance, why are we talking about that today and not 2 years ago? Like, why wasn't that something that you guys said, hey, guys, here's something to consider as we're sitting now having buyer's remorse over some of these higher claims? Those are the areas where I'll just say as a board member, and I think as a board or as an institution, we're looking for your institutional knowledge to help lead and guide our staff and this board in those type of discussions. So we sit here today, we go, hey, by the way, here's one way you could have mitigated that. Well, part of the reason we brought you guys in was to help us mitigate these things. And I feel like, we're already rounding third on our way home on this, and now we're just for the first time talking about it.
So I will say that from expertise or not, I wasn't here when these I was brought to Advent Health a year ago. So as I was brought into this, that was one of the things that we identified looking at the claims information. So we brought it to you as soon as I was aware of it.
And by the way, let me also say this. I'd rather hear this and all of us agree that we missed the mark and have the conversation than not have the conversation and
sure.
realize we missed
Yeah,
the mark. Either way, we're
sure.
going to figure out we missed the mark.
So
right?
I think it's fair to say that we weren't intimately involved in the benefits design discussions that took place with the insurance committee. And in hindsight, there's a number of things that we would have changed. One, we shouldn't be sitting here 3 years later and this is the first time we're having this discussion with the board. Two, we should have inserted ourselves more so in those insurance committee and benefit plan design discussions. We absolutely take accountability for that.
So we'll just flip the page real quick because I think, and I won't belabor all the data on this. Yes, sir.
Let me interrupt one more time.
Sure.
I know you're not going to know the number, but had we had this high claims threshold reinsurance, what's the delta that we're talking about? What's the potential savings that we could have realized
Yeah.
hypothetically in a situation like this?
I don't have the number off the top of my head, but we could do that calculation and get that back to you.
Does anybody in the team have an idea of what that might look like?
We can look at it just real quickly. So can we just run that based on $250,000 high claims threshold?
Okay, yeah, if you guys can do the computations, I just need a general idea.
Right.
Did you say yours is 250 or 350 high claims?
Ours
threshold?
range. It
Okay.
depends on the particular contract, and it's usually based on an actuarial analysis of how much we actually think we'll use.
Right.
It's a trade-off, right? Because you're paying a PMPM to get the reinsurance, and what you don't want to do is pay more in a PMPM than you would actually benefit from the reinsurance threshold. So that's a trade-off. And when we say do the computations, it will be back of the envelope math because we don't know what the rate is
That's all
for a
about
particular
it.
payer for that. So, but happy to do that. So just flipping to the next page, it's a busy slide, but I think a very informative slide. We sent it as a pre-read, and I'll let you spend some time with it afterwards as you see fit. But I think the point of this is, if I look at a population, I can segment that population by risk score, and the risk score basically determines or is suggesting what their likelihood is to spend in the coming year based on all the disease states they've had in the previous year and their spend in the previous year. And we stratify those using a MAR risk score, which is a standard industry-wide risk stratification methodology, and it breaks it down into these 6 categories. What I want to draw your attention to with this is that while the risk scores of the managed in the clinic and the non-managed members seem to match in each stratification very, very well, the spend is significantly less for each of those categories on the managed member side versus the non-managed member side. And I'll let you peruse that as you go down. But that was really what that was to indicate and illustrate. So what does all that mean? And what do we think we can offer differently? I think, again, going back to what we heard when I was brought in this back in the fall from Dr. Pace, was that we have a total cost of care problem. And to be frank, I don't think the model that was set up was directed at lowering the entire total cost of care across the entire population. It was predicated on lowering the total cost of care for those people who use the clinic, and I think the previous slides have demonstrated that, at least in comparison to the normal trend in non-managed members, there is evidence that was accomplished. If we're really looking at a
I would
total...
disagree. If
Sure.
you weren't here 2 years ago, I'm going to disagree with you a little bit. I feel pretty sure as a board when we went into this, it was to lower our total cost of care. And if we did not communicate that, shame on us, but I'm pretty sure we had a healthcare cost problem, as everybody in the United States has, probably the world.
Yeah.
So that's where this started. And,
Yeah, I actually agree with Mr. Thacker on this. I was going to make a similar comment. However, identifying that in one segment you may have found some accomplishments, but in another segment you didn't, meaning managed, non-managed, that's fine. But he's 100% right. We were very clear in the beginning what our expectation is our costs are going through the roof. We have to find solutions. This is one piece of multiple solutions that need to be put in place. And I'm going to go back to the term relationship or partnership. That was really the whole genesis of this, which is don't focus just on the piece that you're directly responsible for, but become a true partner for us in trying to solve our overall rising costs of health care and insurance for this organization. So I agree with you. And I was chair during that process, so I can tell you it was as clear as anything.
My question would be, when you do these calculations, we're spending reoccurring in $3 million a year for our population. That's the, that cost per covered person to Florida Hospital, right? So when we do these calculations, are we dividing that among everyone? Are we actually sticking that $3 million all on the managed members? I mean, because to go back to Mr. Thacker and Mr. Weishire's point, if, to your statement, it's to help the people that are managed by you, then, but we're paying for everyone.
So the cost.
So, I mean, I understand where my
think that's a
question
key distinction.
leads.
Yeah.
But I want to make sure that when I'm looking at these numbers, am I looking at, so you're managing 25, now 33% of the population, but yet we pay
our monthly fees
per member per month, or per member per year, a dollar amount for everyone. And so to go back to Mr. Weishire and Mr. Thacker's point, which I agree with, is that when we looked at it back at those times and had those discussions, it was about everyone and total cost of the entire system for the district.
So the dollars that are being spent on the clinic, both the cost of medical care, the pass-through cost, and the administrative fee, are being allocated back to the managed population.
It's a dark blue bar.
So it's
So
not
none of
being
those dollars are being kicked over.
No.
And I appreciate that.
Yeah.
But Tim already kind of hit it on the head, is we get a report every month, quarter, I'm not sure what it is, that shows we've had 8,000 visits through the first 6 months or something like that. This is the first time I've seen data that shows the, whatever your percentage of the managed, the 33%. So I can tell you, out of ignorance probably, when you say 8,000 people have come to the clinic, I certainly don't think those were 8,000 unique visits. In fact, they were reported as not unique. But when you see the 3,000 uniques or whatever they, first time, we labeled them as something, I can't remember what the term was.
I think they use the 8,000 as their unique number, but 70,000 total, right?
Yeah.
So they're using 8,000 different folks.
That's right. That's right.
So when we look at that, I know you're putting them in, if they went to another place more or whatever, they're not considered in that managed group, but that's a lot of our people that have been there, and I wouldn't say they haven't been back, because I know they could have been there 10 times if they went somewhere else 11 times. They're still not.
Well, every pre-employment physical,
Yeah.
every DOT physical.
Okay,
So
that's
so
good.
all of those occupational
They count as
visits
well.
flow through the clinic,
Okay.
which is great because they taste the clinic. And
Right.
that's by design, so we want them to come
Sure.
back. If you get a
But it
script
sounds
for
like
a blood
I guess
draw
when I
from your
hear
primary
33%,
care,
it
you
doesn't
can come
sound
into
like
the
they're
clinic
coming
and get
back.
your blood drawn. So, we're really trying to serve as many folks as we can through the clinic, and it's not only for the managed people, but the managed people are the ones that say, you're my doctor, you're my primary care doctor, I'm attributed to you for my ongoing care. So maybe that's the distinction. Does that make
And let me
sense?
just say, I would fall into this 33% category board and the 25. I have not been to my old primary care doc, who I know very well, and I still talk to him, still go and see. But I haven't had the need. I've tried the clinic on several things, just simply because I wanted to go experience the clinic, because
Want to taste
hearing
it.
and be able to,
Sure.
to just have these discussions with employees. So I've made appointments for things that I just wanted to go and get checked out, and things like this, right? That I probably wouldn't have done anyway. And I went and done blood checks, and I participated in the weight loss thing, which worked very well for me, by the way. So I've been there. I would fall into this 25 in 2017, and now the 33. So that is me. And I've been very satisfied, and I want to put that out there as we go through this discussion, that I've been satisfied with the care that I've received there. Now, I haven't needed anything extra. But
Right,
I
and
have
it's
been
clear that our
satisfied.
focus has been on the clinic, and that's a fault of ours, but that has been where our focus to date has been, is really driving volumes to the clinic, managing that population in the clinic, getting the claims data, and, that, you're right, that has been our focus.
I'll use an example, which may seem silly, but I think it'll make the point clear. And let me say this too: I respect that you guys will lay out the argument of, look, we've been trying to do the right things in the space that we felt we were most responsible for. When I look at it, though, it would be like our superintendent or anybody saying, look, we focused on elementary education and we did really well there. Meanwhile, the whole rest of our middle school and high school curriculum and achievement for our students is falling off the cliff. And then she says, but elementary's doing great. And we go, that's great, but we've got an entire system here that we've got to keep in place. That, I think, for me, is the regret that I have as I sit here, is I never envisioned you guys being a silo for us. I envisioned you guys being a true partner for us and working across the system so that everything was being solved as part of your solution and your expertise, which is why we were willing to bring you guys to the table in the first place, is you had that expertise that the people sitting around this table, we're not in your space every day. And I would be honest to say that's where I feel like my regret as I sit today is like, guys, I really needed you to be more of a partner in the system than just in the silo, if I were being honest.
No, I appreciate that, and I think that's good feedback. And I think in the spirit of partnership, however late in the game that seems to be, and wherever the disconnect was in terms of the expectation and what was delivered or the areas of focus, I think there is a path forward here where we can significantly address the problem with your rising total cost of care across the entire population, not just the clinic population of those managed by the clinic. And one way that we would propose to do that and to put our money where our mouth is, I think what we would want to do is actually expand to the clinic, all members of the clinic, regardless of if they're attributed to the clinic or they're attributed to another primary care provider, the same in-depth health management services that we provide to the entire populations that we manage for total cost of care, whether we're at risk or not at risk for those particular contracts. So that's chronic disease management, risk stratification, proactive outreach, care gap closure, a number of other features that we all bring as a wraparound service to those high-risk populations that we would bring at no cost, additional cost to SDOC. We would add that to the clinic services as the next step. To help address and begin to move forward addressing the total cost of care in the entire population. Care management would not only help the folks that are managed in the clinic, but it would significantly help the folks that are not managed by the clinic as well and be willing to provide those services. Having said that, the entire network is absolutely critical, and management of the entire network and where the patient flows through the network is going to be critical in managing the total cost of care for the entire patient population. And we think the best opportunity to do that moving forward is to align the clinic management, the wraparound care management services, with a offering of Cigna SureFit to the employees coming in October. The Cigna SureFit product is a product that is a product where Advent Health is the network for those folks. It is a narrow network. It has a significantly and appropriately discounted rate for that narrow network with Cigna SureFit. It is a value-based arrangement where the focus on Cigna side and the focus on Advent Health side is around managing the total cost of care for the population regardless of their affiliation with the employee clinic. And we believe it would be and I'll show you some calculations here on the closing slide, we believe it would get you very close to the target of $7-8 million in terms of decreasing the total cost of care within that plan year by using a Cigna SureFit. In order to do that, because it is a narrow network product, the offering probably needs to be at an offering that incentivizes, a no premium offering that incentivizes employees to join the plan so that you have most of your membership within that plan. And then we recommend, financially incentivizing them to do that by no significant premium with it. Oops, thanks. So you changed the last slide. So where do we think we will get there? Well, we're also willing to put our money where our mouth is and say that if we maintain management of the clinic, if we maintain management of the clinic, we will offer the wraparound care management services at no additional cost to SDOC for the entire population. And if Cigna SureFit is implemented, we think we can hit these financial targets. And if we don't hit these financial targets, and I'll detail them here in a second, then we're willing to put the entire year's PEPM clinic fee at
So the
risk.
administrative clinic fee.
So the administrative clinic fee at risk if we don't hit those financial targets.
How long has Cigna SureFit been around?
January, it'll go live in April of this year. So April 1.
This is brand new?
Yeah, it's brand new from a plan offering, but it is the Advent Health Network. And the interesting thing about that is, while it's a narrow network product from a pricing perspective, it's Advent Health's broad network. So it's all the assets of Advent Health, the 2,700 plus physicians that are in the network, specialty and primary care physicians. It comes with all the analytics services that we use in our Population Health Services organization, the wraparound care management fees. All of those things apply to a population, and we would treat the entire population as we would treat any value-based arrangement or at-risk arrangement.
And Peter, I think...
Is this a Cigna Advent deal, or does Cigna have this with one out of Memphis or Nashville, or is this?
A Cigna Advent deal.
Sarah, from our earlier discussion, my understanding with Eric was that it is available to this board regardless of who manages the health clinic.
It is.
Correct.
It is.
It is.
It is.
But just
It's just a network option through
Right.
Cigna.
It absolutely is.
So just to clarify, I think the other thing to what Dr. Shuck said is that entire network are all participating physicians with our clinically integrated network. So part of the issue with getting to those employees who are not being seen in the clinic today is we have little nexus to them. We have little connection. Under this scenario, they will be seeing providers who are part of our network and have agreed to manage with all of the parameters that and pathways that we've built into the network, and Dr. Shuck has from the clinically integrated network. So it's a very different kind of stickiness, both with the employee as well as the physicians who are part of that network.
And then to be clear to your point, the Cigna SureFit exists with Cigna. This just happens to be a connection to Advent, but you could do Cigna SureFit with HCA or another provider if you wanted.
That was my question.
No,
Cigna
that's why
SureFit
It's exclusive.
It's exclusive to Advent.
Yeah.
Yes.
But it's not exclusive to the clinic.
It's not exclusive.
No, I get
that.
That's correct.
Yeah.
Got it.
Right. But what it does say is that whoever manages the clinic will be required to use the network.
Sure.
So Mark, do you want to spend a
Yeah,
minute on
so let me just take you through this. And effectively what we've done is we've gone back and looked and said, what is the total cost for all members on a per member per year basis? And we made a slight adjustment to impact the full year of the clinic because we only had 5 months in 2016. And then we said, what would that look like if there was an assumption of 3% inflation each year, which is the normal inflationary increase that has occurred. And what that would do is, if you look to the bottom left, $5,663, and this is all employer paid amounts plus full allocation of the clinic cost of this. And then we said, well, where have we actually been? So if we look at where we were at 9/30/2018, we said, well, what if we have a 3% inflation rate based on that over the next 2 years? And the theoretical would be 6,647. So really the difference of those multiplied by the members is about a $9.2 million savings. So in simple terms, yes, you can access the SureFit product without us managing the clinic. That would get you about 10% or $6.2 million. So there's another $3 million that we believe that with all of the resources that we can bring to bear, as well as having the Cigna SureFit network under us to be able to manage more effectively, that will drive that savings as well. And as Dr. Shuck said, what we're willing to do is put our entire fee at risk during that period of time. If we hit this $5,663, we get our fee. If we don't get our fee.
In addition, I would just also clarify that upon extension of the agreement to manage the clinic, we would begin the wraparound services for care management and not wait for the signature. But we would begin that process, and there would be a period of 6 to 9 months in there where we'd be managing those folks already in advance of the signature fit arrangement.
Can I ask a question?
Sure.
You said you'd be willing to put the management fee at risk, but the reality is, if you don't hit the targets, you're picking the money up in the third bucket because it's using your network of doctors and everything. So if you're blowing through and not hitting the target, you're going to pick it up on the back end. So it's, to me, kind of a fake, we're going to let you keep the management fee because you've gotten it at the other end.
I think that's true. That's true of Cigna SureFit's offered period, right? Because for the population that signs up for Cigna SureFit, it's a narrow network exclusive to Advent Health, so they'd be using those services. So I see what you're saying. We're getting fee-for-service revenue on the back end, and therefore putting our fee at risk seems pointless because if we miss our target, we're getting fee-for-service revenue that causes us to miss our target.
The real risk would be we're putting that fee at risk and we're capping the other end also, because then you're really at risk. I've spent a lot of time with the chairman vetting through this stuff, so that would be the real risk if you cap that other end and said we won't go over X.
No, I get that. I guess my question would be is to go back to some discussion we've had with some other folks and discussion we had with Florida Hospital folks. So when we talked about this, it was always diabetics was always a big thing. We talked about that 3 years ago. Here's what we're going to do, and I brought this up at the last health meeting we had with other folks. We heard this already. This is how we're going to fix the diabetics. So what are the numbers? Let's just use diabetics. What are the numbers? How have we moved the needle in the last 3 years since this clinic has been open to change that number? I realize you may not have that answer today, but I remember having that discussion. I believe I remember having that discussion. I won't.
We know Cigna's got data of how many diabetics are in the plan. We know Cigna's got data of how many of those diabetics fill their supplies.
Right.
But I'm almost positive that was brought up, and I apologize, Mr. Thacker, 3 years ago. And correct me if I'm wrong, Board, and I know you're here, Ms. Castillo, but I believe that was something we said, okay, here's how we're going to do that, and this is what we're going to provide to get that done, and this is a big spend, and we know we can put these folks. They would be managed folks. We're going to work on making them managed folks, and if they're managed, that's going to reduce your cost.
Cost of care.
And so,
not in day one, but over time.
Yeah, and I know we've had population shift. The 9,000 that we have today, I don't know the exact number that's different from the 9,000 we had 3 years ago, but I get it. There's some differences there.
But it's probably not.
Yeah, I think
1,000,
If
2,000?
you got 2,000 switched out, that 2,000 percentage-wise
So
probably
I
has
guess,
the same
my
answer.
question to you that I'd like to see the information on is how have we moved the needle on that from that number that was presented to us back in 2015, 2016 until today?
Yep, we'll be
Would that
happy to
be-
follow up with that.
Would that be connected to the A1C
Yes.
compliance piece?
Yes.
Because I know that is a data point that we've looked at with
That's right.
David and the team.
That's right.
Right, that's one measure, yes.
it's one part of a diabetic bundle, but yes.
And that's only because that's just been a topic. Seems like every time we have a discussion with someone about healthcare, it's like, oh wow, we looked at your healthcare and man, compared to other entities,
And I
you
think
just have a lot of diabetes.
Our business, I believe, if I'm not mistaken, runs at a higher percentage than the U.S. population of diabetics.
So the nutrition counseling is part of that, the A1C is part of that, the different services.
Yeah, and I know that's all.
Yeah.
It's part of it. I want to know how
wanna
much
see some
the
numbers?
needle has moved over the last
It's a fair
3
question.
years.
It's a fair
and,
question.
and I guess that would help.
We
I
can get
think
that
that would help me,
data
and
for you.
it wouldn't paint the whole picture.
Sure,
Certainly.
sure.
Just for clarity, for my sake, and I think this would probably help the board. So the fee, the at-risk fee, we're going to get wraparound services. Exactly what does that entail? That would be above and beyond what you're currently providing
Right.
for that $3 million number.
And I will turn to my care management expert here. I think what's been provided at the clinic to date is more care coordination than complex care management. And care management is probably one of the most tired terms in healthcare, to be frank, almost as tired as population health and some of the others, because it can mean so many different things to so many people. Joe, do you want to give
You
a
can grab another chair.
Yeah, please. Do you want to give a detailed just description of the work you guys do in full health management services?
We do need you to come to the table for the mic.
Grab a chair, pull it back.
Sorry to pull you in, but you'd probably be best to address.
Lean back. I'll get you. Fall over.
So the approach we normally would take would be to use the claims data, risk stratify the population, and identify who is moderate or high risk with a chronic illness that's not being managed. And we would provide outreach to those members, do a comprehensive assessment that looks at their disease state, their knowledge of how to manage the disease state, their social barriers. It's really a full comprehensive assessment to understand why they're not managing their illness appropriately.
And that goes into these numbers,
Yes,
right?
so that top half of the pyramid is essentially who we target, along with any referrals from primary care or clinic or whomever. And then we engage with that member, we work with them to create a patient-centered care plan that's targeting goals to help them become independent in managing their condition and resolving whatever barriers they have that are in their way to doing so. Sometimes that could even be ability to afford medications or co-pays or things like that, and our care manager works to get them connected to the appropriate care and resources to support their ongoing management of their disease. Usually that relationship lasts anywhere from 4 to 6 months, and it involves weekly, bi-weekly phone calls and touch base and assessing the patient, making sure that they're on track with their goals and so forth. So it's a real longitudinal approach to managing the condition versus just looking at a disease registry of A1Cs, for example, and seeing who's high and getting them in for a clinic visit. That's an important component of overall management, but that's not true longitudinal chronic or complex care management. So what Dr. Shuck was describing is what I was just talking about. And we follow evidence-based pathways for a variety of different chronic conditions, not just diabetes. We can target hypertension and coronary artery disease, COPD, asthma. There's a variety of different conditions that we can manage in that same fashion.
And within the clinically integrated network specific to diabetes, we have a standard clinical pathway that is rolled out and following, all the clinicians follow the same pathway related to diabetes care. It is tied in with the care management pathway, so it's all one plan of care for a patient based on their disease state and their diagnosis.
Yeah. And we work in tight collaboration with the patient's primary care physician, no matter who the doctor is, actually.
Yep.
And in the other populations that we currently manage today, many of the patients that we identify that need us don't actually even have a relationship with their primary care physicians, and one of our goals is to get them into some sort of a medical home. Whether that physician is a member of our CIN, quite frankly, or not, we want to get them access to care.
Yep.
And a lot of the reason why they're unmanaged is because they don't see a doctor. So our work is really member-facing, and that's why part of the expanded scope is intently focused on the entire population, not just the members who are using the clinic. And because we do have the claims data, we can identify who those people are.
You also identify folks, I'm sorry, you also identify folks based upon utilization as well. So they may not have a high risk score necessarily, but if they have frequent flyer to the emergency room, et cetera, we'll identify those folks, flag those folks, reach out and see what we can identify that may plug them in and decrease their utilization, improve their overall care.
My understanding was that we had someone in the health center who was starting to do some of that work 6, even 9 months ago, correct?
Correct.
And her scope was limited to clinic patients, though, correct?
Correct.
Yeah. So it wasn't the entire population, it was only patients who were used in a clinic.
Only the managed patients?
Yes.
Okay.
So there was answer to your question about the high-cost members. If you would have carried $250,000 reinsurance, it would have been about a $2.6 million savings last year, minus the cost of what the reinsurance would cost. But that's $2.6 million.
Do you have any idea what
Cost of reinsurance.
There's a payback for, reinsurance would be a fraction of that. I think it's a historical number. It's been there for a long time, I believe. And claims did spike. These catastrophic claims appeared to have spiked in late 2016, 2017.
Again, I remember having that discussion about this.
And Board, we can certainly follow up and get the numbers in terms of what the difference in our stop loss costs would have been to lower that threshold from 850 to 250, because that's then, the delta is what your true savings
Right.
would potentially have been, and it could guide our recommendations and your decisions as we move forward. But it's a long-term cost of the higher reinsurance versus the claims cost, and it's a balancing act, just like your deductible on your property casualty.
The only other thing I might say about the care management presently versus what Jill's team is offering is I think that the scope of what Jill's team is offering and the expertise there is much more expanded. And it's not just outreach and care coordination, it is true health management, it is true disease management. It is a programmatic structure with a relationship over a 4 to 6 month period of time that truly drives outcomes. And when we look at high-risk members, really having that care manager associated with their care drives down costs significantly. And we've got case after case after case that across our value-based arrangements where that's where we can demonstrate that effect.
So what I think I hear you saying is that if we were to continue our relationship in managing the clinic in a partnership relationship with Advent Health, the care management would be added as a component of that as another member of the team, and then the SureFit network. And with those 3 components, you're proposing that we could potentially save $9.2 million.
That's correct.
That's
yes.
correct. Yeah.
Okay.
And if we don't save $9.2
I
million, you're...
apologize, I just want to make sure I was clear.
Yeah.
Board, do you have any other questions?
I'll just make a comment. When I got elected to the board back in 2014, I knew I would have some discussions about health insurance because I knew we would have that was part of the bargaining. And what we do here is insure our employees. But I can tell you over the past, I want to say, year and a half, I've talked to more people about health insurance than I ever believed or dreamed that I would. And what I think it says is that we're all in a tight spot. I mean, school districts across not just this state, but this nation, and not just school district corporations, small businesses.
That's right.
Everybody. And so we are in a really interesting time where we're all together trying to figure out what the right path is to take to reduce these costs. And so while it's exciting, it's also extremely challenging to come up with something. But I do think you have a board here that's willing to be innovative, willing to look at a different way of putting something together, to take that risk to a certain degree. And I don't want to speak for everyone, I'll speak for myself. I certainly would be willing to be innovative and take some managed risk. But it is, board, and I'm just making a comment, I'm not really asking a question. It has been exciting. I can't tell you how many people over the past, actually just a couple of months, if you go back into year and a half, it's a ton of folks have come forward with all kinds of ideas, whether it's hospital or things like this SureFit or reinsurance and all these other things. I've heard from so many folks with lots of different solutions. So it is exciting, and we're all kind of in a new world together, I guess.
So this model provides maximum choice for your employee base, because they have the choice of the clinic, and there's an incentive for them to go to the clinic, and that there's no co-payment associated with it.
Thank you for not saying free, by the way.
Right. They also, though, have, under the SureFit product, in a relationship with Advent Health, the ability to access all of those other points of care that are still covered under the same methodologies and mechanisms for how we manage it. That's right. So it does, and that's not just from a primary care standpoint, then that extends into the specialist as well.
Hospitals,
and
the answer.
the hospitals and all of those pieces. So it is a plan that perhaps gives more choice than some other options you've considered. And, again, that's how we've looked at this, and that was part of when we put this together initially. It was important. We wanted to get people to come, but by choice, not by mandate, right? And I think we've seen that when we make some adjustments and we say we can open up from an urgent care standpoint, we can get people in same day, we get more people coming, which is a good thing. That's what we want to accomplish collectively. I think the other thing is that when we started this journey 3 years ago, maybe Ken or Lauren could have predicted the amount of people that would have come to the clinic. I mean, we saw many more people than we thought we would see initially, and many of those people hadn't seen a physician or a nurse practitioner for years. You weren't included in that.
No. I've had to have some small things, but and to Mr. DeBoer and his team's credit, I mean, something that I've always kind of seen, and the data is starting to bear out, is was a plan. Again, I go back to the Polk County numbers that were given to us when we were deciding on this. There is an initial spike, and I think we all understood that going forward, that the guy or gal that hasn't seen a physician in 10 years, and they come forward, they may have some sort of major issue. And so I get that. And so we spike, but then as we get into that primary care, continuing care, care management, whatever the nice word is for it,
Right.
that's when we see the cost starting to drive down. And I guess some of those numbers are bearing out on what you're presenting.
And I would say two additional things. Rate is part of the problem with healthcare spend. The bigger part of the problem is that across the country, 33% of the care we render is either of low value or considered unnecessary care. And that's our bogey. That's what we're trying to reduce, right? In addition, you can have rate conversations, and the Signature Fit is a rate reduction. It's our narrow network rate. But the bigger piece is there's a lot of utilization that we can carve out, and we're after that. We're after that in our physician network. We are trying to disrupt the way we do business as Advent Health system, so that I'm sending people to ambulatory centers for their MRIs and so forth before insurance tells me they have to, because we're responsible for the total cost of care across these arrangements, and I can't be authentic by sending them to the hospital that costs $200 or $300 more per episode. So there is this decrease in utilization, that unnecessary utilization, that is the bogey here, and there's plenty of opportunity to potentially even do better than this, to be honest with you. This is a relatively good estimate, but we could potentially do better. And the other thing I would say is we continue to invest in our network expansion to actually put assets where your employees live and work. We have additional plans to add assets that are in the works 2020 and beyond down here, such as freestanding imaging, outpatient lab, and so forth, that would be easily accessible to your membership. And we can get you the dates of projected openings of those things, but it is part of our network development plan to put those assets here, even outside the relationship with SDOC.
I guess just to kind of finish up on what I'd like to say, anybody that comes forward and however we move forward, one of the big things for me is going to be, because I've been around to all the schools in my district and listened to a ton of employees, and one of the things that I'm going to be very focused on as we move forward is that same-day service. Because I can't tell you, Mr. Thacker's been there, and I know Mr. Weishire's done some. Mr. Soto's been at some of these that we put together, and you have too?
Yeah.
And so, when I hear these things, and look, both my parents were teachers in this county, so I have to listen to all their friends too. This has been the number one issue when it comes to the health insurance. Not just, besides the cost, let's set that aside because we know that's for everybody in the nation. But that's been the number one thing is you've got this asset that you want me to utilize, and you're doing it at no extra cost for me, but I can't utilize it. And so when it comes down to it, for me, I want to see somebody that's going to say, hey, here's what we can do to, you have the flu, you have the cold, you have a sinus infection, you have something wrong with you. I need to be seen, but I work from 8 to either 7 to 3 or 8 to 4 or 9 to 5. And so I want to be seen. No, you understand.
And we heard that loud and clear.
Okay.
And in the last 6 months, you will not have heard that message. We have seen anybody that wanted to come the same day we saw.
We're going to start wrapping up. I don't know if the board's got other
I'm
comments,
done.
but I want to add one Ricky Wentworth, the comment I was going to make, and this doesn't need an answer. It's just something, if we continue with this relationship, you need to think about and have a plan that would convince me. You've got on the very first page, 95% excellent patient or member satisfaction rate. That's fine, I get that. But the thing Ricky's talked about, where we've been talked to all these different employees and staff members, I can tell you, you've got 50% of the employees that have never given you a rating because they couldn't get in or they went one time and they're so
I would say
aggravated,
that
they're not going, they will say, close the clinic, I'm never going back.
I'd say it's
How do
about
we
half
re-
as pleased.
How do we re-engage, how would you, as the operator, convince 5,000 employees that today's different than yesterday? So, like I say, I'm not looking for an answer right now, but somewhere you'd have to convince me you've got a really good plan to re-engage the unengaged.
We'd love to have that opportunity.
So, Terry, you have any other thoughts, comments?
I just need a lot more information, but that's on me because I'm brand new. So I will be extensively looking at more information.
I think I made my point, which was, to be honest with you, we came into this, going back to what I said earlier with the relationship component, and if I were being really honest with you, I feel like we allowed that relationship to drift, and now as we're about to part ways, we're going, how do we re-engage? I still love it, I'm still here, and that's problematic for me, but I'll share this with you too, and these guys all know this. I am incredibly objective in how I go about things. So I will say this, there's literally nothing personal for me in any comment I made or any question I asked today, literally at all. There is though some regret that we're sitting here this time later and having conversations about things that I wish we would have discussed earlier on. And what's happened is that I think the trust in the relationship has continued to deteriorate to a level to where now we're like all sitting going, what do we do? Is this salvageable? And if so, how and what does that look like? Or have we severed it to a point to where it's not salvageable? And that's just me being, I don't know if I'll have an opportunity to sit in front of all of you again and have this comment, or have this opportunity to make that comment. And I think it's the only way that I can be the most honest and the most transparent and the most fair in how I communicate where I'm sitting and what I'm trying to figure out. At the end of the day, for me, and I was going to say it, and Mr. Thacker beat me to it, and I affirmed it, is this was always about lowering the overall cost of providing quality health care to our employees. That's what this always was. It wasn't about a one and done or a silo or a wellness center. And to be honest, it was never about a wellness center. It was about wellness centers. It was about an opportunity to continue to scale how we provide this value and benefit back to our 10,000 lives we cover, our 8,000 employees. And I'd be lying if I didn't say I'm disappointed that we haven't been able to solve it in the time frame that we've had here. But I'll also share this with you. My mind's not made up one way or the other what I want to do. As an individual, it's not. I will continue to reflect, I'll continue to analyze, I'll continue to have conversations. These guys know I've been having conversations at statewide level as well about some of these exact same things, how it impacts other school boards across the state of Florida. And so for me, my head is up, and I'm trying to look at the horizon and say, I can't change what's happened in the past, but I can be part of the conversation of how to change it in the future. And the question for me is, who should be with me, and in this case, us, as we chart this new course. But that's the most honest I can be in the moment that we're in.
We appreciate it, and we have very similar feelings about the fact of drifting apart. And I think one of the things that we would love nothing more than to be able to continue a relationship and prove that we are a good partner from a relationship standpoint, but we'd want to have the ability to do this, because I think absent it, it's easy to grow apart. And the ability to sit and understand early the concerns is important.
I'll make one last comment and apologize, board. And I'll say this just so that you know, because for me, in my heart, I'm a capitalist, and so the word profit is a beautiful thing, and I think it should be for all of us. And it'll make sense that I preface it by saying this. I always knew and respected that there would be opportunity for Advent Health to make additional revenue in other areas in tightening up the relationship with an institution like ours. And I never had a problem with that. But it couldn't be one-sided, and it couldn't be at the peril of us or the people that we serve and represent to the benefit of the network or the system. And so I think that's a very important thing, is that honesty and transparency in how we go about this, and saying, we can all win in these type of equations, but if it's a true relationship, nobody can win more than the other. It has to be equitable. And that's been the piece for me the whole time, is I don't mind that you guys will have more in network or in system referrals. That's fine. I always anticipated that. But how is that going to then trickle back to us as additional savings in this partnership? And that's an important point for you to hear.
Mr. Soto, you want to any comments? Or
I just think that I appreciate the presentation. Very useful information. One of the things that I'm always try to answer in my own mind is how this addresses some of our needs and some of the challenges that we're facing. Being able to maintain a healthy fund balance and continue to provide the benefits that our employees deserve. I think that question is being adequately answered. I think this is very favorable. It'll go far. I'm going to have some more discussions with our CFO to see exactly what this does and how it would look past 1 year, a few years. And if that's what it is, and if I get feedback from our employees that I haven't heard anything negative to your benefit from employees. They do like, generally, the benefits that we provide, including the health care. So, like Mr. Weissayer, I keep an open mind. I view this as very favorable. I thank you.
There are no others. Thank you all very much.
Thank
you.
We're going to recess the workshop for 15 minutes, and we will be back at 3:30.
Thank you.
Frank, you okay to recess?
Yes, sir.
Okay. I didn't know if you were trying to stop.
No, could
We go to the playground.
Thank you very much.
Thank you all very much. Appreciate it.
We will go ahead and reconvene the 2 o'clock workshop of April 16, 2019. And we have Susan Caswell from the county who is going to present a plan on alternative school impact fee for 0-bedroom units, which sounds very exciting.
Doesn't it? Okay.
I'm
Yeah, I don't, if everyone can see this, but I know you have a copy of it. So basically, I was just going to walk through what we did here to do this study. You guys know you have generation rates by housing type. Your multifamily rate is 0.391, but it's not representative of the tiny apartments, the studio apartments. So what we did is we tried to figure out whether there was data out there that would allow us to do an alternative calculation. And I did learn...
The 0.391, is that our current?
Current.
No, that's the old one.
I think that's the old one.
The new one is
For multifamily.
multifamily was like 0.5.
Nope,
I
0.391.
thought it was higher too. Okay.
Maybe the old one was 0.2,
old
and
one
that is
was-
0.1, and the numbers that I specifically asked for were on some of the Section 8 and the government housing, which ended up being almost 1-to-1 and over.
Remember that this is an average, so that .391 would include everything from a studio apartment to a 4-bedroom apartment.
That's right.
Right.
The old one was 0.2,
Yes,
which was way off.
because it
About 1
included
minute ago.
townhomes as well as
Correct.
multifamily.
Correct. That's right.
We interrupted her before she got any.
Yep. She did
Yeah, I
not
have
get
that
it.
Sounds about par for that.
And I was going to say that what I have learned during this whole process is there just isn't very good data from multifamily, and that's part of the issue that I know you guys struggle with. But because this isn't really representative of studio apartments, we started looking at how we could assess this in a different way. So what we did is we pulled some data and we also surveyed apartments, and so that's what's in the study that you've gotten. What makes this possible is that the census data tells us how many rooms there are in a unit, it tells us how many bedrooms there are in a unit, and it tells us how many people there are in a room. And so that allows us to do this. Now, we can only do this for studio. We can't do it for larger units because rooms count living rooms, dining rooms, kitchens, and bedrooms, and dens. And so once you get up into bigger, the multipliers don't work. But what we know about studios is they're either a 1-room or they're a 2-room if they have a separate kitchen. So that allowed us to do some calculation based on the persons per room. So 97% of all homes have 1 or fewer persons per room. So if you have a 3-bedroom house with a living room, dining room, kitchen, and you got 2 people living in it, that's 2 people in 6 rooms. That's how that's calculated. It's not per bedroom, it's per room. And so, and that's why we can't use it for bigger units, only studio, because we know studios are either 1 room or 2.
So you're talking about 97% of all homes, regardless of size.
Correct.
Have
So
1 or fewer persons.
97% of a 6-room house has 6 people in it.
Right.
Less,
Yeah.
less,
Six
yeah.
or
Six or less.
Yeah. They actually have a calculation of half a person per room or less, but I figured, why do we need to talk about half a person? So anyway, but we know the 0-bedroom units have 1 or 2 rooms, so we could do this, but we can't do it for the bigger units. So just to tell you what we did here, because we did have to make some assumptions. There are just over 1,500 0-bedroom units in the county. It's a really small percentage of the county's housing. And so we divided it up based on those percentages of how many people in a room. We divided up those 1,500 units into 1-person, 2-person, 3-person, 4-person. And we're making some assumptions to do this. In all likelihood, there are very few, if any, 4-person studios out there. But based on the assumptions, the data in the census, this is what we came up with. There are 1,383 1-person units, 122 person, et cetera, et cetera. Now, here's what we did from here to estimate children, and we assumed all children were school age, because what we're talking about here is who can live in a unit. So in a 1-person house, of course, that 1 person's not a school child, so that's why that says not applicable. In the 2-person house, if we assume all the extra people are children, what that means is that 2-person house is a parent and a child. parent and child is about, a single parent with a child represents about 12% of households. So that's how we got to the number we got here. So that extra person in a two-person household, there's 14 of them, and we assumed they were all children, even though in a lot of cases you might have two people that are a married couple living together. We just assumed they were all children. In the 3 and the 4, we just assumed they were all children, all the extra people were children, just because the numbers were so small that it didn't make sense to start doing a bunch of calculations on it. So there were 6 3-person units. We assumed all 6 of them had children, so all the extra people are children. That's how we got to 12. So that's how we did this calculation, and what we ended up with was, of the 1,510 units, 21 of them had kids in them, some multiple kids, now, once again, estimates. So 29 kids. That's what that estimate came up with.
So I'm gonna, and board, if you guys all followed that perfectly, then I'll get this.
Okay, that's fine.
I'm confused.
Mhm.
I gotta be really honest with you. Am I the only one, or?
No, it's okay.
I was with
gonna
her
ask
until she
questions.
said 2,900 or something, or
2,100.
Okay, I heard 2,900.
So will you just help me for a moment?
Sure.
The first column, number of people in unit, that literally represents the number of people or the unit, meaning one
Number of
room?
units.
Like, that's where I think I'm getting lost.
They're
These are all 0 rooms.
Right, they're all 0 1 room, and they're
Okay.
all together here. So there, of the 1,500 units, 1,383 have only one person in them.
Okay. That's
120
touchscreen, by
have
the
2
way.
people. And then 6 have 3 people, 1 has 4 people. That's based on the percentages in the census of how many people per room. So that's how we came, so that's how we divided the units up by how many people were in the unit. And then the next thing we needed to do is ask how many children were in those units. And so if it's one person in the unit, it's not a child. You see what I'm saying?
Okay, and all of this, just to make sure I'm
Go
this
for
is
it.
all hypothetical.
It's all based on census data. It's not
Census
based on
data
a
specifically
survey.
to Osceola County?
Specific to Osceola County.
Okay, do
we
we
have-
know,
Oh, no, please go.
Go ahead.
do
Sorry.
we, I don't know if this is even a valid question, but it does help me. Do we know where these 0-bedroom units are?
They don't exist.
We
But they
can narrow them down
Yes.
by census tracts and by type
Because there's actual data.
of, and by type of unit. So some of them are studios and apartment complexes, and I'm going to show you some of those
okay.
examples next. And then some of them are accessory dwelling units, like garage apartments.
Okay, are any of these the hotels? None of, so we don't have any data to say how many?
Hotels are not included in this data.
Okay.
Yeah.
What about the hotel that's being converted to apartments? Is it already permitted and online or not? I'm not
It's
sure.
permitted and under construction, I believe.
Okay, so this 15, those units are
Does
not
not
included
include
here as
that
well.
at all.
Yeah, and that was 300 units that they did the first. I think there's 6 buildings. I think they did the first 50 out of the gate. First 50 units. I think if my memory is correct. on that.
I know they're still working on it.
Yeah.
They're being converted to studio apartments, essentially.
Now, they're being converted to assisted studio transition, so they may actually have kids in them, but they're not part of this data at all.
That was basically my question. Are they a
Right.
part of this data?
My
Because yes,
question would
they
be-
are like transition housing.
Of the 1,383, how many of those are like the 55 and older? And like because you understand what I'm saying?
I understand what you're saying, the data's not there.
Okay, so we don't know.
We don't know, right?
Is
We
it
don't.
safe to assume that some of those are 55
It's
older,
safe to assume
55 and
that.
older communities that have just studio apartments?
Well, I would say the studio apartments, there just aren't that many of them. The ones that I've seen are either in large complexes that have a small percentage of studio apartments, or else they're accessory dwelling units, granny flats. So that's where they are right now.
What about just across the street here at Johnson University? Does that
Dormitory? Is
like
it
a dormitory would not be included in this?
No
Okay.
dormitory, yeah.
What about the 55 and older units that are right off the turnpike?
Now, this does not differentiate between 55 and older.
I have no
So
idea
this
what-
could have some of those in it.
It could, because they didn't have it by age.
Yeah.
I'm
just trying to get to
Sure.
what these are and
Sure.
and where 1,500 of them are. Because I can't, maybe Tim.
She's gonna, when she shows you the apartments, you're
there
gonna
they
see
are.
I don't know
a good
if
chunk
it's
of
there,
them.
but this is.
Yeah, Polo Run and
Oh, yeah, that's, and so,
Yeah,
yeah.
good chunk of
Okay,
them.
So anyway,
I want to go back to one
sure.
other thing. You mentioned something about single-parent homes, 12%. Say that again. It just kind of caught me, like I was trying to process that. What does that mean?
I think it was for two-person households, 12% of them are a single person and a child, a single parent and a child.
I'm sorry.
Versus
I
two
was listening
adults.
to them. Say that again.
For all two-person households,
Mhm.
there's a certain percentage of them that are single parent and child. And that's the percentage we used here to say this percent, I think it's 12%, are a single parent with a child.
Sorry.
And it may not be the percentage of two-person households, I think it's the percentage of families
That
that
was your fault for
constitute
listening to me.
that living arrangement. So,
I know, I talked to you.
I have more.
I'm sorry.
go for it.
okay, because I kind of took a look at this a little bit earlier.
Okay.
This is probably not a question for this at all, just from my own knowledge. How do we factor those families that do live in those hotels and we don't factor them at all? Oh, okay.
Okay. So, I mean, this is just how we got to the number we got to. That's the math behind it. And it's in your report in more detail. So basically, the results were we have about 1,500 units, which is, I think, 1% or less of our total inventory. 29 school children. We assumed all 29 of them were school age. So the student generation rate is 0.019 compared to the multifamily of 0.391. We also did a survey of apartments, and these are the ones that we did. A lot of them are in Osceola, but some of them are in Orange County as well. And what we asked them was basically how big are your units, and we also asked them what is the maximum number of people you would allow to be in that unit, and in all cases they said 2. Now some of them, we did ask them, would you allow a parent and a child, and some of them said no, and we didn't tell them that's illegal, don't do that. But that's why I didn't include that data, because they can't say you can have 2 people, but they can't be a mother and a child. You know, that's illegal. So, but all of them told us maximum 2. And these are some of the local examples that we found. You can see that a lot of them would be 2-room because they have the separate kitchen. Some of them are 1 room, but they're all smaller than 550 square feet.
Like that in New York City one time.
That's like this, yeah.
And Chicago as well.
So what we were proposing based on this information and what I talked about with staff was to add in language allowing the differential fee for 0-bedroom units. So what we would need to do is add a definition, and this is the definition. It limits not only the bedrooms but the size, so no more than 550 square feet. And there's a couple different ways to do this, but you have a section in your impact fee study that acknowledges or in the ordinance that acknowledges the study. So all I did is mirror that language to say you were also acknowledging this alternative calculation.
But would we have to have our engineer do this study, or can this count as the study?
I think they reviewed it, right? This can
We did ask
count.
Tim Oliver to review the study, and they were comfortable with the methodology, just concerned, as always, about the limitation of actual data that we have in Osceola County
My
as a
question
predictable factor.
is, and this was a big sticking point for me on the short-term rentals, when you start reducing one, you have to squeeze the balloon, right? The balloon doesn't get deflated, it just pops out on a different site. So if we're taking 550 multifamily units out and lowering, that means that's part of the reason why multifamily, even though we know some of these apartment complexes have a 1-to-1 generation rate, I mean, from our own numbers that we have in the school system. So
That's how some of them get to 0.4.
this is how they get to 0.4.
Sure.
So if we're going to reduce this one, I wouldn't be in favor of it reducing this one without increasing the others. And so.
And I think they could run those numbers, but there's so few of these units that I don't think it would make a difference.
And that was the discussion that we
Okay.
had.
Such
Yeah.
a small percentage of the overall population
Right.
of units that it wouldn't cause a huge impact.
It's a small population until somebody can
Until
start
we give them
building
until we
these
give
for
them no impact.
$10,000 less.
Then it would all be reassessed in the
Correct.
next study, at which
And I'm
point
gonna address
it would
that in a
have
minute.
to balance
Yeah.
out somewhere.
Because
I'm
again,
gonna
it goes
address
back
that
to
in
less
just a
than
moment.
1% of the inventory currently.
How much?
Less than 1%
1%.
currently.
Right.
That's why it doesn't have to squeeze the other into the balloon.
So
It does,
is,
by 1%.
so you could actually mirror that language and acknowledge this study, but the other way to address this is just to, and there's the number in the table. It basically goes to $552. That's what that generation rate amounts to. And if you don't want to change the language about the study, you could actually just put a footnote here that says it's based on that study. I think either way might be acceptable. And so that's where we end up, is $552 for that unit. So,
Can you
the-
do-
oh yeah. So, and that's just based on the generation rate and the cost per student station, like the rest of it is in the ordinance. So what we would do is amend the ordinance. We would revisit it the next time around, which is it 2021? Is it 3 years?
Doesn't have to be, but that's what we typically have
That's
done.
what you're right. Now, here's the other thing, because we did realize that you don't have the data. The data that exists for single family is so specific, and for multifamily, you just don't have it. So what we've been doing at the county is figuring out a way to collect that. So we can tie every single kid, I mean, you can tie a kid to an apartment. We can tie that apartment number to a number of bedrooms. So that, and that's the piece that's missing. And so.
So why aren't we doing the study ourselves?
So what I was,
Because it costs us and we're letting them do it.
Well, and the board's discussion.
Something we had looked at during our previous study.
And the board's discussion during that piece was, we were going to make our recommendation and ultimately the decision that you all made based on the data that we had, not actual data that might be projected to come
Correct.
based on what's happening someplace else, or an estimate based on things like census data. But based on the actual data that we had at the time, that was our recommendation that landed us to the decision that you made, with the understanding that this board has typically directed staff to revisit this study, and we agreed to revisit this study in 3 years at that time to see if additional data was available. For example, one of the things that we talked about that would be essential to do as well would be at that time to assess the impact of the short-term rental exemption piece that was coming in.
Well, it wasn't an exemption, I think it was just a reduced rate. Like, we separated them out and gave them a reduced rate,
Right.
but that's because they actually have
Generate less.
And so, I'm fine for charging whatever. But again, it has to be, I go back to the balloon, I know this is only 1%, but I would also state what Mr. Thacker just stated. If we do this, everything all of a sudden becomes a studio apartment. Every multifamily unit now will become a studio apartment unit.
If I were asked to make a recommendation at this point in time to the board, I would recommend that we move forward with something like this only if we also develop the deed restrictions, similar to what we did for our 55 and older population, our short-term rental definitions, so that the units would be limited to two persons, as well as then the square footage.
I think one of the issues you might run into there, though, is that they're going to be reluctant to commit themselves to a number for those units because of things like fair housing.
And that's something that certainly our council would have to recommend, because we weren't prepared to make a recommendation at this point in time anyway. But I think,
I'll tell you, my biggest problem with this is not the one-room thing, whatever we call this. It's opening it. What we've not done traditionally is adjust our impact fees until we have a study. And if we start halfway through this time period, we adjust it for this, or we're going to end up with every 2 months, we're going to have something coming here that needs to be an adjustment to impact fees. That's just my opinion. Frank, I know you got
Yeah, I got a couple issues. One, when we did the previous alternative impact fee, purist in impact fees, like Bob Neighbors, God rest his soul, were like, you are in a dangerous area because you're either producing kids or you're not. And if you start saying, well, they may only produce one, the backside is a very clever lawyer could turn around and say, I'm challenging the whole impact fee. Why do I have to pay when they're not paid, et cetera. So I would say I'd like Finance Council to give a written opinion to the county and us saying, you are authorized to do this and there's no risk. Because we're starting to carve up enough
That's
where
what
somebody's
worries.
going to pay attention with dollars. Two, and I said this here earlier on when we worked together on it, I really think the county needs to sunset it. Meaning, in 3 years, unless the county, or 2 years, readopts it, it goes away. Because if it's not working, I don't think we should be fighting to end it or adjust it. But if the data says it's not working and you want to readopt it, then you readopt it with appropriate fees and that.
Yeah, I still stick, it really worries me to start slicing the thing up halfway through, because I'm telling you, in 2 years, somebody's gonna be in here saying, we have found out if we paint our 6-bedroom apartments purple, there will be no children living in there. Therefore, we're gonna have a purple wall.
That's why I really want
I mean, I don't know
Impact
where
Fee
it's gonna
Council to
stop.
give us
They'll
an
find,
opinion. This is,
I mean, people are creative.
I think the difference, or in this case, the unit is structurally limited.
And I get that.
that's-
I guess I don't have a problem with the 2020. When we do the study, my problem is really not these units. It's kind of opening a scientific study halfway through a time period.
Well, one of the
I don't know where
things
if you do this one, why do you not do the next one?
in part because there's no data. I mean, because I was able to use data in a different way than you could do with any other size apartment.
Right.
You can't use that data for a 1-bedroom or bigger. The calculations just don't work.
So a few things I'll share. And we spoke a little bit about this previously at a different meeting unrelated to any of this, and just on a concept level, the market is looking for this type of a unit, and that is a real component. That's really what I think in a lot of ways is and should drive the conversation. So there's part of me that says, okay, so first of all, Clarence, I think you're making a great point, and it does concern me a little bit of what happens when you open that box and then you can't close it again, or it becomes harder to close maybe. The other thing I would add, though, too, on the other side of that argument is the market is where it's at when it's there, right? And so by picking what, from the market standpoint, would be an arbitrary date of 3 years, because that's what we traditionally do the study, we're not really understanding or respecting the market forces that are already at play.
I'm not sure the 3 years is arbitrary, though. It's 3 years or more, right?
No, but I mean, we could do it every 5 years if we wanted.
Right,
I'm just
but
saying
we have
picked it, right.
we have been going to the statutory minimum.
Sure. Yeah, no, I get that. There is one concern that I would raise, which is I have, as a board member, have argued that I've been historically opposed to the idea of using square footage and bedroom count as a metric. And we had our consultant look through that in the last study in detail, and this board yet again decided that that wasn't the way to go. And I guess as I read it, my concern, just meaning reading 0-bedroom unit, my concern is does that then reintroduce a philosophical argument that I just disagree with, where what stops somebody from coming in another year or two, or in the normal 3-year cycle we follow, and saying, well, you did a 0-bedroom unit, now let's just take a look at a 1-bedroom unit. And we end up sliding into a place that I don't think we should be in, and we've made a decision not to go down. That's not a comment to say I don't support this, by the way. It's just me thinking out loud of where I see the unintended consequences. What I did like is the idea of if we went down this road and using it into the metric that we're using of it will pay at its generation rate as opposed to it's excluded. I like that approach more. The last thing would be, and maybe Frank, this is a question for you, the whole premise of this is based upon a limitation of size of the unit, not just makeup of the unit. And so the question is, we would have to put language in there that says a 0-bedroom unit consists of a dwelling unit of less than blah, 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 all that, right?
There's somebody will give you a 10,000 square foot.
Yeah, 6-bedroom unit,
Yeah.
That's why we also put the square footage
In
in.
the first apartment to my wife that I lived in, which was a married student housing apartment, was about 320 square feet with 2 bedrooms.
Yeah. So I have another question is, do we have, and Craig, I'm glad you're here as well, do we have between at least these two entities projects lined up or in queue that people are like, if this passed, I'm ready to go to the market with 2 of these, 200 of these, 600 of these? Are you guys hearing from your development services department like, hey, this is the barrier, and once the school board releases it, we're ready to rock and roll?
I'll be very honest with you. Craig Collins, City of Kissimmee.
Come on up, Craig.
Yep. That's what you get for coming.
Yeah, that's what you get for showing up.
You could have sat out in the lobby and listened to it.
Was safer.
So at the city, we have several apartment complexes moving through our process right now. And we haven't said that there's a possibility floating out there that studios would be reduced, and kind of explain the situation to them. They're still moving forward. I'll be honest with you, most of them go, it'd be nice, but studios are such a small percentage of what we're building right now. It's all 2 bedrooms is really kind of where the market, what we're hearing where the market is. So I think if it didn't change, these will still move forward, assuming they're bright enough to make sure that they've budgeted the money either way. But the next question always is, what about 1 bedrooms? So that's the next question. But we do see, there was a lull when the impact fees first were implemented, and now we're seeing a lot more. We have 800 unit complex going in Tapestry that's probably going to break down here in the next couple months.
It's going to have some of these?
It'll have studios. Again, the answer is very consistent when you say they may go down for studios. That's such a small percentage. Money's money, but ultimately it's not going to impact the bottom line dramatically it's a de minimis type situation.
So your point simply is that the $10,000 savings per door is not going to change what the developer intends to develop?
No, not right now.
We've actually seen some interest, but we don't, we won't know till they come in.
So,
what has driven this conversation?
That was my exact question.
So, one of the things, and it wasn't the back lot, but it was another proposed conversion. And so when they came, these were people from up north, and basically what they specialize in is converting, and this was a hotel, into studios. And the model, which we're starting to see in places and millennials seem to be just fine with, is a very small unit with nice amenities on the ground floor. And so that was what they were proposing for that particular conversion. They would not be able to do it because it was $3.5 million in impact fees. But they would be able to do it if this had gone forward. But what we're starting to look at, and I'm hoping that as we start collecting this data, you might revisit the issue of bedrooms, because what we're starting to look at, especially with the units coming into downtown Kissimmee and other places, where they tend to focus more on 1 bedroom. And I think I told the board months ago about one of the projects I looked at up in Orlando that had 308 units, mostly split between 1s and 2s, in that more urban environment, and it was 15 school children and $900,000 a year in property taxes. So those 1-bedroom units are really valuable because they aren't going to generate as many kids. And this may not be encouraging.
It's kind of like insurance, where everybody's paying a little bit.
I understand.
And as you start to take out everything, we're all paying school taxes whether you have a child or not.
Right.
Because those of us with children in schools could not afford them.
Right.
So it kind of gets to be the same thing. If we only go to the places where we know there's a child, are we going to set that up to where we can't afford to build anything for families with children?
And that becomes part of the thing that we think about as well, which is education isn't just about education
Who
for
has
the
kids?
sake of knowledge
Mhm.
as much as it is an economic driver for any community.
And I-
And so everybody benefits from having a high-quality education system, whether you have a student or you don't. We are providing the pathway for true economic growth and development across the nation in any community
Sure.
where there's quality education.
And I
So
think
that
that's-
becomes who
right.
pays, but we all benefit.
But that's why
So
we
all
have
pay, like,
property
right?
taxes. That's where that comes in. The
I don't
public
need to
good
speak
is
to
paid
that.
for with
But
the property
to-
taxes.
to
but
kinda
the-
go on to-
But the
Tim's-
impact fee is supposed to be based on the impact.
It is, and that's the statute.
But
That's
that's
how
my
the
point.
statute
We
reads.
drive, the impact, the 2,000 kids coming to town this year, or however many it is, are the same 2,000 kids. So, in theory, if we took every structure that's built that doesn't have a child and say, okay, you don't have to pay impact fees, those with children are gonna pay twice as much.
Well, and that's, yeah.
Which
I
now you
understand.
have a community that can't have children.
Which is why you don't differentiate.
Millennials already aren't having
I mean,
children.
you have to look at it for every unit of that type. So you're not looking at this kind of one bedroom versus that kind of one bedroom, you're looking at all of them.
And look, I was actually a proponent of breaking down the whole multifamily, and then, to Frank's argument, that's, there can be some pitfalls there. But if you start breaking down multifamily, you're going to be talking about any sort of Section 8 government-assisted housing paying a $40,000 impact fee to be built. Some may say that's a good thing. But what I'm saying is, if you want to build a high-end studio apartment with high-end amenities on the ground floor, as a community member, to attract, millennials that are, high-tech people, what you're trying to do in Kissimmee and St. Cloud, everybody, right? I'd be all for that. I just want to make sure that we don't get to a point, because I know that the legislature kicks this around all the time, where the homes or the units that are generating the absolute highest generation rates by 2 or 3 times are going to now get a pass, and then here we are back to Mr. Thacker's point. Okay, now we can build these studios for zero impact fee. So the low impact, we're giving them a 0. The highest impact, we're giving them a 0. So who in the end, how do we create educational facilities in a community when everybody gets a break? And back to Tim's point, we're all in this together. Grandma had grandkids, right? Or had kids that went to school and now has grandkids that go to school. So it is a community. The entire community is involved in its own education system.
And some of this too, so you know, is us sharing with you some of our philosophical viewpoints as well. Because I was going to share this, and this board knows it because they've heard me use this example. My problem when we start getting into number of bedrooms is just because you choose to invest more in real estate doesn't necessarily mean you place a higher demand on service. And I've always used myself and my parents as an example. Pam and I buy ourselves in like 6,000 square feet under roof house. My parents buy themselves in a 2,000 square foot under roof house. And we both place the same demand on services, which is next to nothing directly, but yet something indirectly. And yet I pay $6,000 in property taxes, they pay $1,600 in property taxes. And so in essence, the system is designed to penalize me for choosing to invest a significant amount of capital into real estate in Osceola County. And the size of my house or the number of bedrooms in my house is not necessarily what's determining what I have in my home or who I have in my home, as much as is what I want to enjoy, right? And so that becomes part of it. I know that the study ends up washing that out over time because the study's based on the Tims and the Clarences and the Terrys and the Rickies and everybody in play. But there is that piece, just so you hear from me, that I go, more bedrooms don't necessarily always equate to more people, and less bedrooms don't always equate to less people, as we've seen bear out in some of our other communities that come into existence.
But I think I would say.
And a number of bedrooms usage changes over time.
Correct.
You may sell your house next week to somebody with 14 kids.
Exactly.
I think that actually may be an argument for looking at it by bedroom size. What you might find is the generation rates aren't what you think they are as it gets bigger and bigger and bigger. But either way, you
They aren't.
know
We saw
based
it.
on
We
the
saw
data.
it. It was in our last study.
Yeah, So you
But
know
again,
that
there's no
based on the
argument in
data.
this. It's just discussion
Sure.
for me,
Yeah,
just
we're
to
not-
say, just so you know, as you
Yeah.
guys are working through this.
I understand.
Because you and I actually agree on what we want. We had that conversation. That from a market standpoint,
Yeah.
there is absolutely a market and opportunity for these type of houses, and it becomes cost prohibitive for them to be developed in our community and for us to attract a certain type of buyer into our community because of limitation of cost. I understand that from a
Right.
market standpoint. I have to take that hat off, though, and put on another hat which says, okay, I understand what the market's telling me, but I also have to understand what the need and demand of the institution is that I represent and have a fiduciary obligation to. And so that's what I try to weigh out in this.
And the reason I mentioned, like with Soto, for instance, the number of school children and the property taxes per year, and I've looked at your data, I understand the issue that you have with the allocation from the state and all of that, and I think I mentioned the last time I was here, when you look at housing built since 2014, when you cross from Orange to Osceola County, the median value drops by $8,000. So consequently, and the other dynamic to look at is that Osceola County has about a quarter of the population of Orange County, but about a third of the school children and about a fifth of the revenue. And that's an issue you're having to deal with, and I understand that. I think the reason I mentioned what I mentioned, though, is by not the reality is the 0-bedroom and the 1-bedroom do not generate as many school children. They do, however, generate a lot of property tax, especially in these urban environments. And so we just amended the comp plan to create very urbanized centers. And just that, I think Orlando did a study of their downtown apartments, and it's a tenth of the student generation that other multifamily does. So I think there is value in looking at it in more detail, because what you want to do is encourage those types of units that are going to bring you tax value without bringing as many kids.
Is there a reason you're jumping from paying impact fees to none versus?
Well, it jumped to 552, and that's because that's based on the generation rate of
Right,
the
so
formula.
they just pay a
They
different
pay a
rate.
small, yeah,
All right.
but it is based on the fact that it's a lower
About
generation.
0.2 kids, 0.02.
So that's one of the things.
I fully believe there is a market for this type of unit.
I do too.
I can see downtown, probably some of your Mosaic, a few of these, or some of them being perfect for this.
We're not, the two developments that are happening downtown that are multifamily are a very small percentage are studio. Most are 1 and 2 bedroom. There's a small percentage of 3 bedrooms going in.
Yeah.
But we have roughly 500 units planned over the next 18 months for downtown, and the bulk of them are 1 and 2 bedroom.
I think one of the reasons there are studios in a lot of places is because rents are so high. We don't have high rents. You can get them.
We
Well,
do.
yeah, there's.
We have some high
Trust
rents.
me.
It's all
1,000,
relative.
right?
but I was going to say,
yeah,
it's the
well, the
market's
studio-
incredibly tight right
To a
It's
1-bedroom,
1,200.
to a studio, how
Mosaic.
much is the
Right.
rent?
The studios at Mosaic are starting
About
at
150,
1,200.
1,200.
This is
So
ridiculous.
So, yeah, those won't be.
What is it in Manhattan?
What's funny is
A little bit more.
a lot more, yeah. We haven't caught up to
Rich, not
Manhattan
rich.
yet. So.
So one of the things that, because the deed restriction would be so problematic in this case, one of the things I was going to ask you about is, because we are starting to collect that data, and we could write something in there that this will be adjusted annually or whatever, based on whatever data we've collected, so that if all of a sudden it ramps up and we see a lot of people in those units, because we can match them now to the students, we know, and we know in a relatively short time. So we could build in that language that allows us to come back every year and monitor it until your next update.
Frank, I was going to ask you to comment on that.
I haven't looked at, but I want to look at the ability to do a deed restriction, because a lot of people just throw out, not you, a lot of people just throw out law as, well, you can't do it because of the law, but when you really turn the pages and look back.
But she just talked about changing it every year. I don't think, that doesn't sound like that would be something that would be allowed.
adjusting it every year.
Yeah, because we could say we could put in our ordinance.
They're only going to be begging to change them in one direction.
What I would suggest, though, you could.
Somehow it doesn't work,
not to
because
change
if
it
you
so
buy
much as
the
to
argument,
sunset.
something else is
If that happened.
underpaying.
Now you don't have to worry about adjusting.
Where I'm at is, if we're going to, my recommendation, if we're embarking on something that's unknown territory, you have a definitive date it goes away unless it gets passed and approved to go forward. Because if you just look at our own legislature, they pass laws and then it's impossible to ever get them off the books. This would have everybody do an intelligent analysis to keep it.
And that's what Susan was just suggesting, that if the deed restriction piece is problematic, they're going to be able to gather more accurate data than we've had in the past to be able to track kids to specific bedrooms and units. Then perhaps the clause would say that should the student generation rate go up by X percent, this
sunsets till
provision
the
would
next
sunset
update, or-
until the next update or, further review. I'm just, that was what Susan was just saying. I don't think the rest of the board had an
What
opportunity.
about this, is just a thought. If you look at our short-term rental rates that we are charging, due to data issues and disagreement between data, we've kind of picked a number. And that number is higher than what the short-term rental developers would tell you it is, but it's lower than the regular single-family home.
Right. It was about half, right?
It kind of cut the thing in half.
Yeah.
Going to $500 sounds awfully low, and I kind of feel like I'm not sure. Is there a number closer to the half range that gets you to the 2 years, to 2021, when the next study comes? And then, I mean, Mr. Holland's telling us that right now, nobody's running out of the room screaming that they're not going to do it at the other rate. I'm just kind of thinking.
You can speak for yourself, and that's just for those two developments.
Right. Okay, you're right.
So let me say. So I track with you, and
Just thinking.
I'm intrigued by the conversation. One thing to bear in mind is and I've said that there is a market for this, but this market is not as. It has a lifespan to it as well.
That's what we're
But here's my point: is everybody thinks, and there's a misnomer out there that millennials don't want to own homes. Not true. Every national study shows that over 87% of millennials do want to own homes. They still see it as part of the American dream and their opportunity to build long-term net worth. So what we tend to do when we talk about these things is say, well, we're excluding millennials from a marketplace, and these are intelligent, capable people that we want in our communities that drive economic activity. They shop at our coffee shops, and they go to our restaurants, and they do all these other things. This segment is hot right now. There's also a market trend that's in existence for micro living. But remember, there was a market trend for McMansion living as well, only 10 years ago. And so the market kind of adjusts itself along the way. Right now, it's very on trend to live a minimalist footprint. In 5 years from now, people might go, you know what, that sounded really great. I really need to stretch out, right? I really need room. And the market will adapt to that. So I say that just because I know that there's an opportunity, and my concern with your point about the number is, and you know this from your work, mathematically, if this number is too high, it still becomes a barrier to the opportunity for it to manifest itself. The other thing is, just don't anybody think that this is going to continue to bear out as like, oh my gosh, the market's going to be amazing, and for the next 10 years, there's an opportunity, but it's an opportunity as a piece or a part of this, not the end all to be.
And that was kind of what I was making on the cost of the things. When nobody can afford anything, it drives it a little bit.
Yep.
And the cost of housing moves, incomes move. So there are some people choosing it because they like the little homes and this, that, and the other. I'm like you.
Yeah, and I was part of a national study called Housing 2.0 about 4 years ago, 4 years, I don't know, that analyzed all this. The next 50 years of real estate development in America, what will it look like? This is a part of it. It is not all of it.
The only thing, if I may, sir, just caution the board, is that number for short-term rental is based on data.
Yeah, it was.
No, I know.
It just didn't adjust. We didn't
To
adjust
zero.
what we were taking out.
No, we had different data points
Right,
that people were arguing about. and we chose
Exactly,
a-
and so that's where I think it would be hard for us to come up with a number that's not based on data. This board has been very consistent in saying that you are going to make your income impact fee discussions based on real data that we could bring forward. And that's what Susan has tried to do here with the census data and estimates based that, from a planning sense, I think, I'm not a planner, but are logical and reasonable.
Well, we had data on short-term rentals. We
Right.
had 30 years of
It was
history on what had happened. We don't have data.
What does
30
this
years
do
of-
as well, as you say, there is value here. So what does this do if we just drop the value of these things by $10,000? And you say, well, I wanted to live in downtown Orlando, but now I can live in Kissimmee for $10,000 cheaper. Right? I mean, because the value of the home, the value of a studio apartment, this is built into the home price, correct?
Yeah, but I think you mean cost, not value.
Well, if they all have this cost added,
or reduced,
the values go up, right?
So if we drop it from $10,000 to $500, the cost of the structure is not going to drop by 90. It's not going to go to the consumer. It's going to go to the developer.
In the market, I don't know. I have to think about that, Ricky.
Yeah, no,
Because
it's a good.
because there's a difference between cost and value.
No, I understand that as
Yeah.
well, but if every home is being charged that then becomes a piece of the overall value, because that's part of what you have to pay. Everybody has to pay it. If you're going to build a new home, this is going to be built in. So whether you buy an existing home or buy a new build or decide to build a custom home, and that all has to be factored in, right? So that would have an effect on the price.
Do any other counties do this?
Yes.
Break this piece out?
Yes. Broward County does it, and their generation rate is similar. So I think, and Craig has kind of talked about what the reaction is. I think what we would probably see in the next couple of years is the apartment developer who comes in, who's got, his mix of 40% ones and 40% twos and 20% threes. He finds this out and he plugs in a small percentage of studios just because he can, there's a market for them and he can get this fee. And so those are units he probably wouldn't have built otherwise, but those are units that come online with the rest of them, and you can tell me, but they're not going to charge differential rents based on the impact fees. They're going to put all the impact fees in a pro forma and it all works and they charge market rents.
And that's not where I was headed with
Yeah.
that. But I think you kind of understand what I'm saying. If that is a part of the cost of building a home,
They're already building them $80,000 cheaper now. They're selling them for
That's the
$80,000. They're selling them for $80,000.
Yeah. We do need some sense of direction, board, in terms of what you would like in terms of next steps. Do you want?
Like the senseless direction.
Well, this is what I don't know, maybe I'm alone on this, guys, but I think my sense of direction is thank you. Let's let the board think about it. We'll follow up. I don't think there has to be a do this, don't do this.
You wanted us to do something.
I think, at least for me, it's the beginning of a more in-depth review of the general concept. You've put some data before us for us to kind of think through. I think, the chairman made some really good points about, is it really the right time? Let's say even if it's the right thing, which I don't know if it is. Is it the right time? Does it undermine
That's much more
our
my
process?
concern than
Sure.
the concept,
Yeah,
by
so,
far.
I'll tell you, for me, I don't have an opinion, like, don't do it, do this, retool this. I think I need to kind of noodle it myself a little bit before I do anything.
And I think Craig mentioned that, the word is out that this is being contemplated. I guess my question would be if somebody, because the way the ordinance or the way you deal with alternative analyses, if somebody does an alternative analysis based on certain factors, the next guy could come in and say, well, I'm just like that one,
Sure,
and use
that's-
that as backup. So I guess my question would be if somebody were to come in to do an alternative analysis with this backup before you decide one way, would you just handle that the way you do any other application for an alternative analysis?
Yes.
Okay.
Yep. They'd be just like anybody else who gave it to us, and we'd analyze it. But I think
Okay.
I agree with Mr. Weishauer, by giving us some time, we can have more dialogue. I really want us to talk with the county's Impact Fee Council, that we're not jeopardizing the other impact fees with some creative legal attack, because there'll be somebody who tries to raise that. You know, we got one right now trying to say that they want all the impact fees back that they paid prior to July 1 or August 1, right? The reduction, make an argument. So I think we look at that and we can noodle it down the road, but at least we can get clarity on that issue and make sure we're totally zipped up.
Yeah, and I don't, it's the same can of worms. Is everybody now, or short-term rental people now going to come back and say, we would just redid our study,
Yeah.
6 months into your new plan, and now we think it needs to be changed by 10%. Do we want to, is this, and I don't know, this is what concerns me, is that because this is actually a reassessment of multifamily.
Yep, it is a reassessment of multifamily, and to be honest,
So
I
how
don't
does-
think
so-
folks in the
I don't know,
multifamily
I'm
business
just-
want a full reassessment of all the multifamily, to be honest with you.
You are moving, that was when we did the last one of the things that Bob Neighbors was concerned about was if you start carving this up, you're moving in the direction of somebody saying, I only have 1 bedroom, I only have 2 bedrooms, I only have 3 bedrooms.
Yeah, I got
And
6
getting into-
offices and
I don't know
one
the
bedroom
answer, that's correct, but I just know,
Sure.
all I can do is make sure that you guys are fully informed about the ramifications of any decision you're going to make.
Absolutely.
And so I think we need to
That's
just.
where I'm at.
And I think,
Susan, I don't think you have a
Susan-
consensus.
I understand.
Right. Susan, I think that's a second prong we want to look at. If our board gave the green light, is there a way to make sure during the period they gave the green light and the next analysis, there's no way anybody's coming in and nickel and diming us to change everything on another area? I think then each one would have to come in with their own analysis, and that costs so much. Most of them don't even want to go down that road.
Is Broward the only county who has his alternative
I think in Florida.
in Florida?
But
How
a lot
long
of
ago did they do it?
They've been doing it for several years.
And that's purely from an impact fee standpoint, educational impact fee.
Sarah will follow up to get a little bit more information.
The benefit is
I mean, I can anticipate the answer to the question is immediate, but what your goal today was, I imagine, to leave here before going, hallelujah, let's do this thing. What's the, yeah, what's your, in your mind, what's your timeline of what you're wanting to accomplish?
Well, I think when we had talked, the idea was we would come in and talk about it and then come back in a month or so to get direction. I mean, to figure out what it is you want us to do.
Okay.
So, yeah.
Okay. And then my follow-up is, I know in some of your other presentations and referencing SODO and things like that, have you done an analysis or study of areas, let's say just to use that, Orange or Seminole, where there is like SODO or maybe Land and House and Nona or some of these where we go, hey, look, where these product types have come online, here's what we're seeing from an economic impact or from a development standpoint.
Yes.
Because one of the things that this board does talk about is, for us, it's not just a simple thing of, okay, we have to make this little decision. We have our heads up, and we're looking 10, 20, 30, and 50 years down the road about our job is to not just make decisions that impact what we do today or tomorrow, but the future of our community. And all of us are incredibly invested in making the decisions we think have the best long-term viability and success for this community as a whole. And if you can point to instances or cases, and I think SODO is a good example, but it's an example.
Right.
Where it say, hey guys, look, in this area, similar markets too, don't bring me San Francisco, right?
Oh, no, I never, yeah.
But
No.
in similar markets where like in our region, this has happened here, this is what we're seeing, and this is what happens as a result of it.
Yeah.
I think that might be at least beneficial for me from a processing standpoint. I'm glad to try to leverage some realtor assets to try to help you through that analysis, but that I think is going to be an important piece. And I'll use Clarence just as the example on this. He said, and we all have, including Booth and others, but Clarence, I think, has been the loudest of saying, look, we need to make sure we're building housing in Osceola County that actually can sustain Osceola County. When we talk about what we're constructing, it can't be 225,000. It doesn't generate enough to support the services that are then demanded as a result of that from your institutions and from ours. And so that's an important piece in how we look at making decisions. It's not one and done as a simple in this area. We want to think big.
Sure.
So.
And I think one of the things I've been told when we talked to our board about some of these issues, it was think about single family and multifamily differently. And in part because one of the things we're doing in the comp plan is trying to rejuvenate some of our underutilized commercial corridors by allowing a mix of uses, which helps with transit, which helps with the retail, providing the rooftops for the retail. And the Soto example is one where I think I may have given you the numbers at the time when it was a strip shopping center with a movie theater behind it. The taxable value is $5.2 million. Here we are, 10, 12 years later, the taxable value is $91 million for that one piece of property. And that piece of property has basically catalyzed redevelopment all around it. And so that's where, balancing the taxable value and the impact fees, especially for units that we really do know aren't going to generate kids, is something that would help in the long run.
I agree. There is also another piece, too, which is what happens in one area doesn't necessarily mean it's going. You and I had this conversation about other development corridors around here, and we can put together these ideas and concepts of what, in our perfect world, what that would look like, but the market's going to tell us that's never going to bear out that way. And I'm a fan of Soto, but I think, do I think tomorrow we're going to develop something like that here? No. I just don't know that our market is prepared for that and has the momentum behind it to support it today. We need to lay the groundwork for it for tomorrow. But I just don't want us to lose sight of it. It's easy. Here's what happens. Everyone tells me, oh, look what's happening in Nona. We need to do the same thing. It's Nona. It's not just because it's Nona. It's location, it's airport, it's proximity, it's all these other variables that contribute to why it's doing what it's doing. It is anomalous in its nature.
And those people,
fronting money for restaurants.
I can tell you, those people don't realize the airport's there till after they've moved in, and then they have a problem with the planes.
Yeah, and then I watched them. I had a bunch of cameras today, and I watched them just flying over.
So, I've been very vocal on this, as Mr. Weiser said, is that there's what the market can bear, and there's what the community can bear. So I think as a school board member, I've always asked, myself, when we talk about things like impact fees, is can the community bear the market? And if you're not adding value to this community, if you're not adding something to this community that's going to help the community move forward, that's a question I've always asked here, and I will continue to ask.
And the county did as well, and that's part of the reason for the recent comp plan changes was the fiscal analysis of these different areas and what will sustain us long term. And so that's hopefully part of that.
And so I get it's not an answer of I need a $350,000 home to pay for parks and schools. I do,
right?
But and infrastructure, but it also means we can't have too much of one product. Because we understand the generation rates are too high and the road usage and infrastructure usage is too high. And the community cannot bear a lot of these types of products, some of which we're still talking about. So anyway.
I'm just looking forward when you're on the county commission and I play back the videotape of your comments here. So
you said that.
We can count on the vote.
While you're both here too, by the way.
Better be adding value to this community.
This is an important conversation. I'll just speak ahead of everyone else that's in our facilities department here. This is also where the county and the cities can make sure that you're really being mindful of what the comp plan and what the development standards placed on schools and institutions like ours is as well. And I hearken back to Toho High School and the ordinance surrounding trees and what we had to deal with there, remember? I understand the ideal scenario of what the cities and what the county want to achieve, but we also look at it and say we have to be partners in this because we're tapping the same base. And as much as we need to develop, whether it's a decel lane and the length associated therein, whether it's an extra meeting in the middle of a road, whether it's the number of tree counts and caliber that we need to put on a site, all of which all of us want to see our community, including our schools, be the most beautiful facilities that they can be, but they all come at a cost, and they come at a cost to the same people that we all represent. And those costs are also part of what drives some of these conversations. And so be mindful of that as you guys are working with our facility staff and the superintendent around those conversations. Is we're always looking to the county and the cities to say, are you really partners with us in these areas, or are you placing additional onerous burdens on us from a development standpoint that just drive the cost and end up having a negative impact on our community as a whole. So while you're here, as a school board member, I want to share that with you.
Okay. Anything else, Board?
We made it go longer,
Yeah.
15 minutes.
No, Susan, anything
Not
else?
yours.
Craig?
No.
Okay, thank you.
Nothing else. Thank you all very much, and we will adjourn the work.
Thank you, by the way, for all
Thank
your
you.
work on this, too. You put a lot of time into developing, a lot.